Hello, I'm Elva Arredondo and delighted to have the opportunity to present at the Colorado Pragmatic Research and Health Conference. In this presentation, I'll share the lessons that our team has learned from formative data in our efforts to translate an evidence-based intervention into practice. I'll also share some recommendations based on these findings. My research has primarily focused on Latino communities, but many of the principles and lessons that I will discuss today can be applied to diverse communities. But first, I'd like to acknowledge my team and those who've helped develop and test intervention, and also acknowledge the number of people who have helped me think through the steps needed to translate faith in action into practice. I pursued public health because of my passion to address health disparities. As such, I approach my work with a health equity lens, which involves implementing interventions that are embedded in communities and strategies that are culturally appropriate for the communities that I'm working with. Here's one definition of health equity, which is the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. Using a health equity lens means taking into account social determinants of health, like social integration and social support systems, and making sure that people have access to culturally appropriate and effective interventions. And from a health equity perspective, we need to consider prevention. Prevention is important for populations that have relatively higher chronic disease risk associated with poverty and other determinants of health. In this slide, I'm highlighting some disparities in meeting the physical activity guidelines. As you can see here, Blacks and Hispanics are less likely to meet the physical activity guidelines compared to non-Hispanic whites. The challenge that researchers face in promoting health equity is that many evidence-based interventions are not translated into practice. In the case of physical activity, studies show that only 6% of physical activity interventions go to scale. This means that many of the populations that need these programs are not accessing them. In the context of chronic disease prevention, we have opportunities in community settings to reach those who may not have access to regular medical care. These settings include churches or faith-based organizations. Churches are credible organizations and play an important part of communities' traditions. In the case of Latinos, this is where many Latino families celebrate quinceañeras, baptisms, so they celebrate a lot of these traditions in churches. We can also find volunteers to help implement program activities in many churches. And in many churches, we can also find space to implement a lot of the programs that we're interested in promoting in public health. Churches support values around healthy living. There's health-related scripture, readings, Bible verses that highlight the importance of taking care of one's body. And churches have high reach of minority communities. According to the Pew Report, 35% of Latinos attend church services a few times a month, and 39% report attending at least weekly. We also have data showing that there are over 300,000 religious organizations in the US, so many opportunities to promote health that would reach diverse communities. Because churches are feasible settings to promote health, we completed a group randomized controlled trial with 16 Catholic churches. Faith in Action targeted multiple levels of the social ecological framework to increase physical activity primarily in church-going Latinas. We identified and trained community health workers from the churches to implement the program activities. And we involved community health workers or promotoras because they're trusted members of the communities that they're part of. And they have a deep understanding of the issues faced by their own communities in accessing health and social services. They're also able to culturally tailor the program to meet the needs of those that they're working with. Here's a snapshot of the study design of Faith in Action. As you can see here, each of the churches that were selected to participate in the program were randomized to either the physical activity intervention or attention control cancer prevention condition. And each church that agreed to participate in Faith in Action committed to participating for over the course of 2 years. Once the churches were recruited, we recruited participants to participate in program activities also over the course of 2 years. We assess those individuals at baseline, then 12 months following baseline and 24 months following baseline. The primary outcome of the study was moderate to vigorous levels of physical activity as assessed by the accelerometer. We also collected self-report measures. In this slide, I'm presenting a map of the churches that participated in Faith in Action. We included all Catholic churches from diverse contexts. So as you can see from this slide, some of them were more suburban areas and others in more urban settings. So quite a diversity in different types of settings. And once the promotoras were identified, they were asked to participate in a 6-week training program. And this included training on the benefits of physical activity, proper warm-up, cool down, injury prevention, how to develop and lead walking groups, as well as develop and lead cardio dance classes. They were also trained on strength training, nutrition, and motivational interviewing. At the end, they were CPR and first aid certified, and over the course of the 2 years, the physical activity specialists held a number of different booster trainings. Each church had 2 promotoras to deliver the program, and they were tasked to lead 2 walking groups, 2 cardio dance classes, and 2 strength training classes within those churches. They were also asked to, before they did the physical activity program each day, they were asked to talk about nutrition, talk with parishioners about monitoring physical activity, goal set, physical activity, and manage their time in terms of incorporating ways to engage physical activity throughout the day. The promotoras held the physical activity classes in the church, but when feasible, they held classes in nearby parks and surrounding neighborhood. To target the interpersonal level and facilitate social support and social cohesion, the promotoras conducted 3 motivational interview calls the first year. During the calls, they would discuss with participants barriers to physical activity. They would provide social support to engage in physical activity, and it would also be an opportunity for the promotoras to remind participants about the physical activity classes that they were offering in the church. To target the environmental level and increase access to community parks and trails, the promotoras organized park cleanups and advocated in City Council for improved parks. You can see here there's a before and after picture. This is where they engaged a lot of parishioners to do these cleanups in parks. So at the end of 12 to 24 months, Faith in Action demonstrated significant increases in moderate or vigorous physical activity. The program was accepted into RTIPs, or the Research Tested Intervention Programs. That's part of NCI, and considered to have high dissemination capability. We were really excited about the findings, and we were interested in scaling up Faith in Action. We certainly didn't want this program to sit on the shelf. But as a team, we realized that there was still a lot to figure out before we can scale up Faith in Action. And we needed to understand a lot of the barriers and facilitators to implementation before we can take this program to scale. This is when I became aware of D&I research, and I'm grateful for the training that NCI and MTDIRC provided me and my team to develop the tools to explore ways to scale up Faith in Action. We conducted interviews with various stakeholders to explore barriers and facilitators to program implementation. We conducted a pilot study during the implementation of Faith in Action, where we interviewed church leaders and staff and also promotoras, and we linked that data to implementation effectiveness. And this was with a subset of churches within the larger trial. But we also conducted interviews with Faith in Action church leaders at the end of the trial, and we also included interviews with church leaders from different denominations other than Catholic churches because we wanted to expand this program to different denominations. We also conducted interviews with community organizational leaders to better understand their potential involvement in supporting a physical activity program in churches. So over the next few slides, I'm going to share with you a list of 5 lessons that we learned from interviewing these stakeholders and considerations to help move an evidence-based program in churches into practice. So we're using a lot of these lessons to inform an implementation study that we're hoping to implement in the near future. So the first lesson that I wanted to share is that we learned from these interviews that there were organizational level factors that influence program implementation. So the fit of the intervention within the church context is important to consider, and so is the availability of resources within the church. So we were able to link these 2 domains with implementation effectiveness. In Faith in Action, we focus our efforts in testing the impact of the program at the individual level, so the effectiveness. But it became clear during the interviews that taking into account the context in which these interventions are embedded is really important. Here's some quotes from some church leaders who participated in Faith in Action that I wanted to highlight. So one pastor noted, "You can't just take care of your spiritual side. You have to take care of every part of you. If somebody's coming in hurting physically or emotionally, and if that's not taken care of, it's difficult to focus. It's difficult to allow God to work with you." Another pastor noted, "I believe that healthy people are more in tune spiritually." So clearly these 2 pastors were able to articulate the link between spiritual health and physical health. We also observed that resources available in the church was linked to program implementation effectiveness. So churches that had more rooms available and staff had a much more engaged parishioner community in Faith in Action. So the recommendation would be to assess organizational level characteristics that may facilitate or impede implementation. And it will be important to collect these data early on. In the case of Faith in Action, we found 2 important factors that facilitated implementation: the program's alignment with the church context. Certainly, one can assess the potential fit by collecting data during the pre-implementation phase and see if church leaders are able to articulate the link between spiritual health and physical health. But it's also important to consider the type of program that you're interested in implementing in the church. So more simple programs to implement would be a cancer screening program compared to a more complex intervention like physical activity. And churches may be ready to implement one, but not the other. The resources available, like not having rooms and limited staff, also played a role. So developing a checklist where you can understand the types of resources available and the number of resources available for the church to implement a program ahead of time would be important to also assess. This might be able to tell you whether the church is ready to implement a program like Faith in Action or a similar program, and that would be important to also understand early on. When we interviewed church leaders from Catholic churches and non-Catholic churches, it became evident that there's great variability within and between faith denominations. So there's diversity in doctrinal differences, there's organizational differences, there's cultural differences. Different churches use different Bible translations, and that's important to consider when developing and adapting a program. There's also organizational differences. So understanding the decision-making process within the churches would be important as well. In some churches, the pastor is the only one who makes the decisions on the types of programs that can be implemented. Whereas in other churches, there are committees, and those are the committees that need to get the buy-in for a program like Faith in Action to be implemented. And some churches are much more reserved in terms of the kinds of music that would be allowed to be played in a physical activity program, the type of attire. So understanding the protocols and understanding potential restrictions would be good to consider at the beginning. Because there's so much diversity between the churches, it's important to adapt the program to the values and religious teachings of the church being considered. So this would mean tailoring the messages to consider the different types of scripture and paying close attention to the Bible translations and values of that church. There are a number of different ways of doing this. There are some effective tools available like Adapt, which helps make decisions on what to adapt while preserving core elements of the intervention. Assessing the channels of communication will also be important to consider. So some churches let us know that the only way that they connect with parishioners is through the bulletin, whereas other churches, they have constant communication through email. So getting a good sense of how they engage the church community would be good to understand early on. The third lesson that I wanted to share with you is that we observe different levels of church leadership engagement, which range from agreeing to allow us to implement the program to seeing some church leaders participate in the program and role model physical activity. In Faith in Action, we work directly with the promotoras to implement program activities without directly engaging the church leaders. Our formative data suggests that having church leaders role model activity could inspire physical activity among church members. So here's a quote from a promotora who led some of the physical activity programs in Faith in Action. They, meaning the parishioners, see him, meaning the pastor, walking around in his warm-up suit, and people get motivated. However, many of the church leaders noted that they were not equipped or didn't have the confidence to promote physical activity in their churches, and that a training in health behavior change would increase their confidence in doing so. So here's a quote from a church leader that notes the importance of really providing a training. They, the diocese, never taught us that in preschool, meaning behavior change. So certainly considering that early on would also be important to do. Because church leaders are influential role models, targeting their health practices and giving them the tools to encourage others to engage in healthy living would be important and could help facilitate implementation. Of course, this is no small feat. We know from interviewing church leaders that their schedules are really packed, and a program that's going to be short duration and working around their schedules would be something that they would consider. During the interviews with church leaders, we discovered that churches that had greater connections with other organizations were more likely to report having more resources. This was an important finding because community organizations like churches rely heavily on donations, and these resources are directed towards the priorities of the church. As such, the recommendation would be to increase the capacity of churches to form connections with outside organizations. We learned through the interviews with community organizations that strategic partnerships with outside organizations would be of great value and could bring in resources to the church. So an example here is that the YMCAs noted that they had resources available to support physical activity programming in the community, including churches. And the value proposition for them in doing this would be that this could increase their visibility in the community that they're working in, and also perhaps increase their membership by having more visibility. Whereas with the churches, they see this as also a very valuable partnership because the YMCAs would be able to fund a program, physical activity program, and this would free up any resources needed from the church to implement such a program. Another example that came up during my interviews with hospitals in particular one where hospital leader noted that many hospitals have resources set aside for community engagement activities. And they would potentially invest and support a physical activity program in churches if we were to demonstrate a reduction in potential heart attacks, lower blood pressure, and diabetes, because this would be a worthwhile investment given that a lot of the resources are spent in ERs and treating patients who have these conditions. However, some churches do not partner with secular organizations, so one would need to develop a program to help them navigate these collaborations. And this could be done through collaboratives, advisory boards, and so forth. This is an area that we're starting to explore, but it seems like a promising approach to do that. And the final lesson that we learned from these interviews that I wanted to share with you is that we learned through the interviews that the outcomes of public health outcomes are not a priority for many other churches or other stakeholders. So testing the effectiveness of a health program is not likely to be as important to church leaders compared to researchers. Church leaders may be interested in seeing a much more engaged community with various ministries. So thinking about ways to measure this would be something to consider. Because the priorities of public health programs and churches are not in perfect alignment, to consider scaling up a program, one would need to consider the value that a program would add to that organization. So for this reason, it would be valuable to understand and assess the types of information that the stakeholders would like to see being collected. So I noted that some churches would be interested in seeing greater church membership engagement in the ministries. So perhaps thinking about ways to measure that. And hospitals, as well as some church leaders, noted that diabetes rates are really high in Latino communities. So being able to demonstrate that the program is having an influence on those metrics would also be of value to these stakeholders. One can certainly collect a lot of, and get a better understanding of what's of value during the pre-implementation phase. A brief note about selecting a D&I framework. There are a number of useful frameworks available in D&I research to help guide the implementation and sustainment process. Our formative data suggested that the PRISM model would be a good fit, as it takes into account aspects of the inner and outer setting that may be related to the REA metrics. PRISM helps researchers consider the intervention from the participant and organizational perspective, and it also counts for organizational participant characteristics. PRISM is guiding the implementation strategies that we're considering in the implementation study that we're hoping to implement in the near future. For example, we're proposing to develop a health behavior change workshop for church leaders as an implementation strategy to target the organizational perspective of the intervention. Using the various domains of PRISM that I include here, we can see by asking some of these questions, we can see if some of the implementation strategies are actually having an impact on implementation outcomes based on these dimensions. So in conclusion, even when testing effectiveness, it's important to assess organizational level characteristics early in the process. And one can do it during the development of the intervention and certainly prior to implementing a program during the pre-implementation phase. And hybrid designs can be very useful guides to be able to accomplish this. As a function of my D&I training and this experience, I certainly approach my work very differently, and I think about the end product first. Our team is in the process of developing an intervention promoting physical activity in pre-adolescent girls in partnership with the YMCAs and school systems, and we're certainly interviewing stakeholders from those organizations and trying to understand how to best fit the program to fit the mission and the values of those organizations. And I cannot emphasize enough the importance of considering the value of a program that the program brings to the partnering organization from the stakeholders' perspective. This was a notable theme during our interviews with church leaders and those from community organizations. It's important to consider as it certainly has implications for not just implementation, but also sustainment. So as we think about how to scale up evidence-based interventions in non-clinic sectors like churches, there are a number of research areas that need further exploration, and ones that I've been reading about more recently. Testing implementation strategies like targeting the health practices of church leaders and the extent to which these strategies impact implementation outcomes is a growing area of research. And within that, understanding the mechanisms of change in which these implementation strategies exert. So for example, if we were to develop a training workshop for the church leaders, we would expect that the workshop is going to facilitate more confidence in them in implementing the program and perhaps role model physical activity in the church context. And that could be the mechanism of change that may influence implementation outcomes and potentially effectiveness of the program. We also know little on the sustainment strategies in church contexts. So certainly another area that needs further exploration. As a next step for our team, we hope to take into account these data to inform an implementation study. So in conclusion, to address health disparities, one needs to not only consider the intervention strategy, but also the implementation approaches early in the research translation process. Accounting for organizational characteristics that may impede or facilitate implementation and make health programs more accessible to communities who experience disparities. I would like to thank you for joining me today. I look forward to your thoughts and questions, as well as learning from many of you this week. Thank you.